All right, let's learn about perfusion and blood pressure. An overview of what we're going to talk about. We're going to talk about our goal, our objective, a plan in order to be able to do this, and then we'll end with a list of what you must be able to do for your patient. The overall goal is to keep your patient's circulation, ventilation, oxygenation, CVO, in a good status. When there's problems, you need to find those and fix them quickly, safely, efficiently, and understand what's going on. So the objective for patients with circulation problems, those that have hypoperfusion or shocky, is to fix the circulation while you continue managing ventilation and oxygenation problems. It's not one in exclusion of the other two. It's a concurrent, at the same time, simultaneous fixing of all three of the major problems. So we're going to talk about your plan, and your plan is to assess, then think, then act, and then do it all over again. So, a little background. Remember, there's three components of the cardiovascular system. They all have a role, and they all are interactive. They interact with each other. One depends on the other. And so a problem with any one of them or all of them may be why your patient's not perfusing adequately. So assessing that your patient has an adequate perfusion is one thing, but then understanding what's going on is important. The three components of the cardiovascular system are the pump, the volume, and the container. The pump, heart, moves the blood volume around in order to carry O2, glucose, electrolytes to the cells, carry away waste material. Very basic stuff, EMT level, just to review. And this all occurs within the context of a container, the vessels that provide pipelines for those movements. So pump, volume, and container, nothing new. How do we assess? The first step in our plan is to assess. And how do we do that? Apparently it's 6 o'clock. Sorry. So we're going to assess right off the bat. Assess a patient's perfusion by assessing their mental status, their skin condition, their peripheral pulses, whether those are present and how strong they are, and then their estimated heart rate. Your initial assessment with your hand on a patient's radial pulse is to just determine if the heart rate is slow or it's okay or it's fast. I don't need you to count it right off the bat, but do that quick estimate. Then assess their ventilation and oxygenation. Remember CVO, circulation, ventilation, oxygenation, they're all interactive. They all matter equally. Assess them all quickly and keep doing that. Don't get focused on one and forget about the others. So there's assessment, and then there's some thinking as well. So once you do that initial assessment, estimate of their heart rate and their blood pressure by feeling that radial pulse, now you want to actually measure those things. And that is probably going to be done with your helpers. But you need good data. So make sure you're getting good, accurate readings from good helpers that you can trust. As you approach your patient, check the radial pulse, and then introduce your partner. This is Joe. He's going to check your blood pressure and get a good, accurate reading going on while you continue to do some other things. Once you get your data, then you're going to think. Think about the factors of the blood pressure. So what goes into making a blood pressure? What goes into perfusion? Well, there's two major areas. One is the cardiac output. Is the pump working? And the other then would be what's going on with the container, the systemic vascular resistance. Now, cardiac output is defined as the amount of blood pumped in 1 minute, which is obviously the amount pumped with each pump, the stroke volume, times the number of times the heart beats, the heart rate. Stroke volume and heart rate make up cardiac output. So, cardiac output could be an issue if either the heart rate's too slow or too fast, or the stroke volume's too low, or both. Continue thinking about what else factors into the blood pressure besides just cardiac output. Systemic vascular resistance, SVR, the amount of peripheral vasoconstriction that's going on. In other words, how big is the container? How clamped down is the container? That's what SVR is. Think about which of those factors is causing their hypoperfusion. We're not going to just do cookbook medicine here. We're chefs. We have a recipe, but we need to think and adjust as necessary as opposed to simply say, well, heart rate's low, so I'm going to go do this. So think about what's going on. If that heart rate's too low or too high, then the heart rate's the problem. If that's not a problem, then let's look at stroke volume, and maybe that's too low. And let's talk about how we can adjust that and make a difference for your patient by impacting their stroke volume. Maybe their SVR is too low. So let's think about those. So cardiac output, is it low because of the rate? Maybe the rate is just simply too slow. It's pumping adequately, but it's not pumping often enough. Heart rates in the 30s and 40s, it would be extremely unlikely that those are producing a decent perfusion because the rate is just simply too slow. What if that rate's too fast? The ventricles actually take time to fill. It's physically necessary for there to be adequate filling time. So rates that, in the 140s, 150s or higher, you really don't have much time to fill. So even though the rate is way up, the filling time has created low stroke volume. So if it's not a rate problem, maybe the cardiac output's low due to stroke volume. Maybe there's just not enough blood coming back to the heart, inadequate preload. If they've lost blood volume, or for whatever reason they aren't having adequate preload, your heart can only pump out what it gets in, and so preload can impact stroke volume in a major way. It could also be that the pump is just not squeezing hard enough. So maybe there's adequate blood coming in. In fact, maybe there's too much blood coming in for what the pump can actually pump out. So what about this preload thing? Is stroke volume low due to low preload? Maybe that's a volume loss, or maybe their peripheral vasodilation has occurred. The container's too big, and there's just not enough blood coming back. So you have to think about all these things in order to know which thing to adjust. Could cardiac output be low due to the stroke volume because the ventricle's just not pumping well enough, like we mentioned a little bit ago? Why would a ventricle not be pumping well enough? Well, maybe this person's had an acute MI. Infarcted or injured ventricular tissue is not pumping adequately. There's some movement, but there's not a good squeeze. Maybe that's from one really big MI that they're having right now or just had, or maybe they'd had previous MIs and they're having another one, and that just finally added up to where you have a large amount of left ventricular muscle mass that's not really pumping. Maybe they've had chronic hypertension. Maybe that left ventricle is very thick and very large, but the chamber in the ventricle is now smaller because of the thick, large, hypertrophic ventricular muscle. Maybe that's the case. Patients with chronic hypertension have this problem. The ventricles push against resistance for so long that the ventricular muscle, like any other muscle that pushes against resistance, the ventricular muscle becomes thickened. And so thick muscle means a smaller chamber, which means less volume in there for the heart to pump out. Then you can also have temporary issues with ventricular function. Patients that are septic, patients that have a cardiomyopathy of some kind, may have a temporary, hopefully reversible, drop in their ventricular function. So maybe it's not cardiac output. Maybe the rate's not a problem. Maybe the stroke volume's not a problem. Maybe the SVR is just simply too low. Maybe there's too much vasodilation due to some medication. Nitroglycerin can do that. You can put your patient in a situation where they're so vasodilated there's not enough preload coming back. Maybe you gave the nitro in order to reduce the preload, but there was a little bit overaction of the nitro that you weren't anticipating. Maybe it's due to meds. Maybe there's vasodilation because of sepsis. So sepsis is particularly deadly because it impacts your left ventricular pumping. It impacts the left ventricle and doesn't allow it to pump. You don't get enough stroke volume. Plus, it also causes peripheral vasodilation. So maybe your septic patient is hypoperfused because of a combination of too low SVR and too low a stroke volume, making inadequate cardiac output. Then another possibility would be a neurogenic shock situation where the container is inappropriately large. Blood vessels are no longer receiving commands to stay somewhat constricted. They dilate, and you end up with a very large container and therefore reduced SVR, reduced preload, and now you've got a problem with pressure. So there's a lot to assess, and there's a lot to think about, and you need to be prepared to go through this assessment and thinking about this and do it over and over and over until you're very ready to understand what's going on, so then you can act. Then you can choose the correct action to take. So what are some actions that you would take, and in what order? Which of these things do you fix first? Well, if the heart rate is the issue, if the heart rate is up because of a cardiac arrhythmia problem, then that is the issue. Sometimes the heart rate is up in order to compensate for a vasodilation or inadequate pumping. But if the heart rate is way low or way high, and that is the issue, then work on that first. If heart rate is not the problem, or once you have it under control, then let's move on to stroke volume. How do you deal with stroke volume? Well, you would want to increase their preload. So lay them back some, lay them toward supine. That works nicely. And give them some fluid, unless their lungs are already wet. If they're already fluid overloaded and they have crackly lungs, well, then giving IV fluids to increase preload is not going to work. And laying them back is not going to be helpful. They're not going to let you. Then in that case, you may have to switch to positive inotropes. So remember that stroke volume is about preload, and it's also about ventricular pumping. Perhaps you can give a medication, a positive inotrope, something with a beta-1 impact, such as a dopamine or an epi, that will be a positive inotrope that will cause increased stroke volume. Maybe that's how you fix it. Or maybe if the SVR is the problem, if they are vasodilated, then maybe we need to directly deal with vasoconstricting. If the vasodilation is the problem, then maybe you need something that's positive alpha, such as a norepinephrine or epinephrine or dopamine at higher doses, greater than 10 mics per kilo. So know your tools. Know when your tools will work and what they're to be used for, and think. We're not just going to grab something out of the toolbox and try to give it. We're going to think about why we're doing that. So if your heart rate's too slow, what do you do about it? Well, you can take off the brakes or you can push on the gas. Maybe they just have too much parasympathetic tone. Atropine's great. Atropine blocks the parasympathetic system. It's a parasympathetic antagonist. It blocks the brakes. It takes off the brakes. And so maybe there's a conduction system problem. Maybe there's an AV block that's causing this bradycardia. Look for that cause. Determine that rhythm. Know which rhythms atropine will work for and which ones atropine will not work for. So the first thing we're going to do is to try to deal with the brakes. It's drive-through medicine. It's like you're sitting at the drive-through. It's time to move up and pay your bill or get your food. What do? Well, you take the brakes off first. If that doesn't get you moving where you need to, then you push on the gas. So, what if we said it's a conduction system defect? Maybe that's an AV block. Remember, the conduction system defects we're talking about are any kind of block. An AV block or a bundle branch block, they're all caused by the same list of causes. Just the AV block occurs in the AV node or just below the AV node, and the bundle branch block occurs further down the system. So remember this list, be able to recall this list of 6 things that cause conduction system defects, whether they be AV blocks or bundle branch blocks. Maybe the person is old and their cardiac conduction system is just wearing out. Maybe there's a disease in the cardiac conduction system, so age and disease are 2. It could be medications that have caused the conduction system to slow, negative dromotropes that have caused the conduction system to slow, or a parasympathetic agonist or something that's caused their conduction system to be too slow. It could also be drugs, street drugs, or other toxins. It could just be an electrolyte problem. Maybe their sodium's not right, their calcium's not right, the potassium levels are high or low. But it could also be ischemia, and we put that in capital letters to remind you. Here's the deal. When you have a conduction system defect that you identify on EKG, you need to look for ischemia. You need to look for an occlusion in their coronary vasculature. And you need to look for those clues on a 12 lead with ST elevation, ST depression, T wave changes, You need to look for the C in RPM ABC. That's where this comes in. We're looking for changes that would indicate ischemia, injury, or infarct. Those can cause conduction system defects. You don't think it's the most common cause, but it's a cause that we can identify. And so we're going to look for those and try to deal with those. So what do? You've identified an AV block that's causing a slow rate, that's causing reduced cardiac output, that's causing reduced perfusion. If they're unstable, blood pressure is terrible, altered level of consciousness, acute congestive heart failure, when they are unstable, you need to pace. Pace whenever they're unstable. As soon as you identify they're unstable, don't mess around with anything else. But if they're not unstable yet, then atropine may help. It may help that are in blocks that are in the node. Not infranodal, but intranodal. So these are typically Mobitz 1 or a first-degree block and some third-degree blocks. If you're looking at a Mobitz 2, a second-degree type 2, a Mobitz 2, or a high-grade block or any of the variations of second-degree type 2, then atropine's not going to help because you're trying to block the system that isn't even wired in to where the block is. Type 2s are infranodal, atropine's not going to help. Some third degrees are also infranodal, some are intranodal. And so atropine's reasonable to try in your not unstable yet patient. Again, take off the brakes before you try to push on the gas. Once you've gotten all you're going to get out of the atropine, or it's not going to work, then you move on to something to push on the gas. A beta 1 agonist for positive chronotropy, going to look for an epinephrine or a dopamine. And again, dopamine at that 5 to 10 mics per kilo per minute range is the beta 1 range on dopamine. And that's what you're going to use to push on the gas. All right, quickly, what if the heart rate is too fast? Why is it too fast? What would you do about that? Okay, so too fast, we need to differentiate between fast as a compensation, as a compensatory mechanism. So sinus tach needs to have its cause treated. What are the causes for sinus tach? An extremely fast sinus tach is probably something pathological. It's probably not that just that they're angry or hurt or scared. It's probably that there is significant hypoxia, significant hypoperfusion, maybe some sort of toxin, cocaine, meth, those sorts of things. That's how you deal with sinus tach. You find the cause. But maybe it's just a problem in the AV node with conduction. Maybe it's an SVT, either an AV nodal reintratachycardia or an AV reintratachycardia, one of the SVTs. And so maybe that's the problem. Maybe you can reboot the AV node. Maybe it's a ventricular tachycardia, a VTach. Adenosine can work for that as well. So you've got tools in your toolbox. You need to know them and understand them at a deep level. What will adenosine do for you? When is it safe and appropriate to try it? How do you draw it up? How do you give it? What's the dose? All those sorts of things. It also might be that you need a calcium channel blocker. Maybe you just want to slow conduction through the AV node. Maybe there's atrial fib going on, and there's a whole bunch of little fibs getting through the AV node. And if you could just slow the conduction down, you're not going to get them out of atrial fib, but you're going to control the rate, control the ventricular rate. You do that by causing the AV node to block more of the fibby waves coming through. And Diltiazem does a good job of that, as do other calcium channel blockers. Diltiazem, the one that we use mostly. Sometimes amiodarone is what we're going to use for VTach. So we're kind of talking about the toolbox here and trying to give you an idea of when we use what and why. And this is all about based on perfusion and issues with that. So kind of in review and in summary, you need to assess, think, and act. Assess your patient. Estimate the heart rate, then measure it. Assess their skin condition. Skin condition tells you a great deal. Cool, pale, and clammy is not normal, and it typically indicates hypoperfusion. Measure the heart rate, measure the blood pressure, consider their mental status, do some assessment, and then think. Is this a problem with heart rate, a problem with stroke volume, or a problem with systemic vascular resistance? Where is the problem? What's causing this? And then you do something to act on it. Fix that heart rate if that's the issue. We tend to focus on fixing heart rates first. Then we can move on to stroke volume. Either adjust their preload, if possible, give them some fluid unless they're fluid overloaded, and then maybe add on or move to inotropes when fluid isn't going to work, and then deal with their SVR. But let's work on fixing heart rate first. So assess, think about what the problem is, and then choose your appropriate action. So, okay, here's the last slide. Here's the things that you should be able to do. You must be able to do. Mrs. Smith needs you to be able to do this. Needs you to be able to assess and identify hypoperfusion. Altered mental status, cool, pale, clammy skin, heart rate out of whack. You need, and then eventually, once hypoperfusion is significant, you have hypotension with it as well. So assess your patient quickly, efficiently, have a usual plan, check their radial pulse, check their skin condition, introduce your helper, get some accurate measurement of the blood pressure and heart rate, get your EKG on, determine if your patient's unstable right off the bat, and if so, take immediate action. Cardioversion for the tachys, transcutaneous pacing for the Brady's, and you may need an IV to give some meds if they're not unstable yet. Analyze that EKG, determine your meds, your dose, your volume, how to give it, all the logistics that go into this. This is what paramedicine is about. It's about putting all of these discrete skills together to take an action after you have figured out what the problem is. We think, and then we act, and then we repeat it all over again. And we learn from each of these cases, and we build experience, and we become very good at critical care medicine in a very challenging, logistically difficult, dynamic environment without complete information. This is the art of what we do. There's a lot of skills that go into this, but the biggest, most important skill is that you think. And you need to be able to recall what causes blood pressure problems, perfusion problems, what about the parts of the cardiovascular system, what's going on here. Think. Then you can help Mrs. Smith, and then you're a real paramedic.